G'day, Peter. I'm Dr. Brian Tan, Chief Health Officer for Salesforce APAC.
Always a pleasure, Brian. I've got a few episodes in the back catalogue for people to learn a little bit more about you. But for those unfamiliar, and they're here right now, give us more context. People know Salesforce. It's in healthcare and becoming increasingly important. Tell me more.
Oh, okay. Well, always a pleasure to spend time with you too, Pete. We always have fun during our chats. For those who don't know, Salesforce, best kept secret in healthcare, I always joke. We're in tens of thousands of healthcare organizations here and globally. Essentially, it was born as a system helping organizations understand everything about their customer. So it was a customer relationship management system. And that is the inception of the product back in the late 90s, early 2000s. Since then, it has obviously grown, and we've invested in healthcare in probably about the last decade in particular, building out a set of solutions that are industry aligned. So the core data model behind the database is aligned to FHIR-4 principles and inspired by it. And at the heart, it still preserves that idea of a person at the center of the database. And then helping organizations, in this case, health and care organizations across federal, state governments, hospital districts, and then aged care and disability providers as well in the network, understand everything about the person who they serve, whether that's their staff member or the customer, the client in some cases, or the patient. And then also presenting that view of the person over their lifetime and beyond just the clinical concepts alone, also everything about their social determinants of health, what's their home situation, what's their relationship with the community as well, which is at the heart of a CRM. But then leveraging, instead of just the commercial objectives, understanding what's the clinical application of that, and how do we use those same understanding of the person and their 360-degree view and the relationships that they have to better support their care, whether that be in aged care, acute care, primary care, secondary care, or disability as well. Now, the scale of the platform is one of its strengths, and that comes from the fact that the whole platform is built on a low-code environment, which means instead of doing a whole bunch of custom code, it just so happens you can build these things through drag and drop and configuration rather than coding. So it enables large organizations like the federal government to build huge population health platforms at scale. We built vaccine solutions for an entire state in the course of about 3 weeks. And that was actually the international average for Salesforce solutions, providing a whole estate platform. So it's also helping to architect the way we think in healthcare about the potential for technology to actually make a big difference on a wide scale. While the solution itself is focused on the individual person, the scalability and the capability to build out workflows for an entire, 100,000 user population in 3 weeks, that's just redefining the way we think about how to create a solution.
Yeah. Look, I find that fascinating because, I've followed along Salesforce for quite a while within healthcare, and the more we talk and the more I kind of see these use cases and these problems to solve and the requirements move quickly and the pull the data from different areas, that use case becomes clearer and clearer. So I appreciate that kind of perspective there. Look, I mean, here at HIC, and you've always got the best lawn on the expo floor, can I just say? So the lawn maintenance is high. However, I noticed there's a few different activities happening on stage. There's actually conversations even happening in your own area there too. So talk to me about what you've been sharing at HIC.
Yeah. So we've been sharing that idea of person-centered care, but at the same time, the ability to innovate. And what's emerged, and the aha moment for CIOs everywhere right now, is we have this stability layer. A lot of us have invested in clinical systems, ERP systems, billing systems. A lot of them are not necessarily fast-paced in terms of the ability to create new workflows within days or weeks, unless you submit a change request. So they need an additional tool in their tool set that allows them to create workflows at speed and at scale very quickly. And so the low-code environment is this aha moment where there's a bimodal approach with a stability layer and then an innovation layer of tech tools that allows them to also do pilot projects, new workflows, embed that into the mainstream very quickly. And with the new wave of thinking around APIs rather than the old concepts of HIE, we're only swapping a distinct set of data around problems, allergies, medications, immunizations. Through APIs, we can unlock the value of the data in the underlying source systems, have another layer of APIs which kind of set governance, process rules, things like that, interpret the data, and then another surface of another layer of APIs that then allow those data items to be surface to any application that you create. It's not a Salesforce conversation. This is a whole of ecosystem conversation. How do you enable organizations to then have multiple systems at play and unlock the value in their source, slower moving systems while allowing an application layer then to do cool stuff? And it may not be a Salesforce application, maybe any other applications, but you've already unlocked the value of the source data there to use it in multiple instances, whether it be a diagnosis concept for a staff member to use during their triage workflow, or a nurse to use during their medication administration task, or it might be a patient who's wanting to access their problem list so that they can share with their GP. You've unlocked that data through APIs, and then whatever the app is on the top, that is true interoperability there. You're not defining what you're able to swap anymore. You're actually unlocking everything in your source data.
And so, here at HIC, a lot of different conversations that be revolving around these conversations and these problems to solve. Are there any kind of key message? And you've already outlined quite a few in terms of what problems need to be solved and where those customers are kind of needing that assistance and the capability. But over the last couple of days, there's a lot of interest and excitement from all different parts of the ecosystem about what we need to do. Where are you putting your priorities, or what can we look forward to seeing from Salesforce, particularly within the APAC region over the coming?
Our priorities around the innovations that our clients and our partners are able to enable. So we had Steve Canaris from the Chief Information Officer from Metro South. So as the federal government already has utilized low-code platforms for a while, and then state governments have as well during COVID, during the response, I think we're starting to become a known entity at a hospital level and local provider level. So Steve was able to share, their vision for innovation and why they've chosen a low-code path. So I think it's a brilliant opportunity here at HIC to essentially share the new wave of thinking around how do we enable innovation faster at speed and build on the systems that we already have with APIs, augmentation layer for low-code environments to create the front end for workflows, do patient engagement beyond just the portal. What we're also seeing is that concept of the digital front door just being a website. There's a potential there to entrench inequities in healthcare because you're forcing people who speak English, are digitally literate, and have access to digital tools and devices to go through that front door, and anyone else won't be able to. So do we need to also rethink the idea of a digital front door concept, or one door to a many doors to care, and stop using the term necessarily one digital front door and actually start talking about many doors to care? So not just a portal, but then also whatever person has communicated in their own language through an SMS. We know as we step through our consumer research through different age groups, there's different channel preferences. So is it a longer form email, or is it tilde, too long didn't read, don't send me the long email, just send me a quick SMS link and I'll access that information at the proper time. Also the prompts, the reminders in the moments that matter. How do you engineer that through a platform capability that has all of those capabilities? I think that's a different kind of system and a different kind of discussion than a lot of front-end providers have had, say, in the last 10, 15 years. And so how we're also leveraging a lot of that technology that actually has been utilized in other industries already too. So we've got Robert Connor Dawes, another client that uses that API approach in clinical research. It's not just about clinical practice. This is also transforming the way we think about the unlocking the value of data for clinical research purposes as well. And so there's a lot of fodder for conversation that we've been having at this conference around. It's not just about redesigning your clinical processes and workflows, it's also about redesigning your capabilities for clinical research using real-world data and your own internal systems, which currently are sitting in Access databases and Excel spreadsheets and things like that too. There's a lot of that happening in clinical research. So, and the opportunity we know, the burning platform is that, 30% anecdotally of trials, clinical research actually successful. That means that 70% of our investment in time, energy, resources in clinical research is failing. So there is a huge burning platform and a potential impact there that if we change the dynamic of the conversation, we could improve things dramatically. And that impacts individual people's lives, obviously. Some of these clinical trials are for people who the only access to a life-saving drug is on those clinical trials. They're not necessarily TGA-approved drugs, for example. And so this is potentially life-changing at an individual level. Although we're talking about population-level scale, it's actually affecting individual people.